into that headspace of, you think like everyone else has got COVID, what would you do to protect yourself? And that is about washing your hands before you touch your face. It's about keeping the 2 meters of distance, all of those things as well, which is, I think, really important. The second message that I'd really ask your help on is, if people have to leave home to go to work, please, please, please get them to access the lateral flow testing that's available. And Dina will talk a bit more about that later. We now have in the city ability to do about 15,000 lateral flow tests a week. Now, that's still not enough for everyone to have every day, but it's a huge amount, and that's not including what's done in schools or care homes or for NHS staff. So for businesses that are still bringing people into work, I'm particularly keen for people that work in the restaurant trade, who are working in kitchens, for example, still cooking the meals that we can order by takeaway, getting them to test every 4 days or every 3 to 4 days with lateral flow will help us stop outbreaks happening in those workplaces, because they are happening. And if we can test people who haven't got symptoms regularly with lateral flow, we will find them. And I think that's a really important point to try and get across. In terms of my kind of wider update, I think the final points I just make is, and some of you will have seen me saying this on social media and in the radio earlier this week, we are heading into the darkest days of the pandemic now, I hope. I hope not because I hope they're going to be dark, but because I know they're going to be dark, and they are going to get very, very dark. I anticipate the peak pressures starting in the NHS. So we're bad now, we're about to get much worse, probably towards the middle or end of next week. And they're going to stay up there for probably 3 to 4 weeks, if not longer. And to put that in perspective, that means going from where we were 2 months ago with maybe 40 patients a day going into our hospitals with COVID, to potentially seeing more than 250 a day going in with COVID. And that's because we know what happened in the community a month ago, and that's now translating into people becoming so sick they need to be in hospital. So we are entering a very, very difficult time for the NHS, and it is going to be really challenging, and it's going to stay like that for many weeks. The vaccination will help, but it won't start to have an impact on hospitalizations probably until mid to late March, and on deaths until May. We will see, we will see a lot of pressure on the system, and in these difficult times, people will be exhausted, they will get snipey, angry with each other, everything else. And my ask of you as champions is to help people remain calm, to remain sensible, but also to recognize they have a part to play, and that part to play is about stopping this virus spreading. We can't do anything about what's going to happen next week. Those people have already caught COVID now and are getting progressively sicker. But we can do something about how quickly that pressure on the NHS reduces, and that's down to the decisions we all make over the next couple of weeks. So please do get that message across as much as possible. So I'll just pick up the last couple of questions that have been put in the chat, and then I'm going to hand over to Dino because he's the kind of star attraction today. And I know we've also got Dr. Alida Aladina and Dr. Rizwan also from the CCG to help out with some of the vaccine questions a bit later. But just picking up those quick questions in the chat. So C said, is it permissible to drive to an unfrequented open space rather than a local park? I know this is a bit of a bone of contention, but the guidance is clear. You should exercise locally as much as possible. My advice would be, if you can avoid driving somewhere a long way away, then I would. I have to say, my intelligence from friends and colleagues is that Lickey Hills has been pretty packed the last 3 evenings, for example. And that's not from people who live within walking distance from Lickey Hills. You can see it in the car park. So my advice is, please, exercise locally rather than drive to a beauty spot. It is much more sensible if you can. the police are going to be more proactive in stopping people in cars and saying, why are you out on the road? We are seeing more cars on the road than we saw in the last lockdown. So they are going to be challenging people, and they will be fining people. And, for the next couple of weeks, please exercise locally. Please try not to travel if you can avoid it. Paul just asked about, does the annual flu jab make any difference to the COVID vaccination? The answer is no. We know that having your annual flu jab just before your COVID jab is not a good idea. And that's because there's trying to teach your body to defend itself against two diseases simultaneously is not very sensible unless they are designed that way, like the MMR jab is. So so you can't have your flu jab within a week of your COVID jab, but other than that, there's no relationship. H asked about Birmingham Uni have got yet another new test. I have to say, Birmingham Uni is one of the unis that have been really good at just coming up with new technology. We cannot use technology that has not been approved. Oh, great. Someone says it's Hannah. Thanks, Hannah. We can't use technology that hasn't been approved by the Medicines Healthcare Regulation Agency. It's one of the reasons lateral flow can't be used at home except in exceptional circumstances, because at the moment it's just not considered accurate enough. So once these new technologies have been found, they go through a process to be approved by MHRA and then by the Department of Health. And that does take time. So there are some really great steps forward. There's a spit version of the swab test. So rather than having to stick something up your nose, you get to spit in a pot. And I definitely can't wait for that one to come real, because I'm somewhat fed up of sticking swabs up my nose every week. But they do take time to come. So patience, it will come. And then second part of the question about if you've had the coronavirus already, really about the protection that it lasts, and should we still vaccinate people? So the evidence we've got now, and we've been looking at natural immunity for some time, is still that natural immunity wears off. So we thought originally that people who had COVID had natural immunity for about three months. We now think that probably lasts for about 4 to 5 months, but only in about a third to 2/3 of people. So a third of people who have COVID don't learn. Basically, their body doesn't learn to defend itself. And of the 2/3 that do develop some form of antibody reaction, about a third of those, the antibodies they develop don't work properly, so they don't defend themselves. And then another third forget really, really quickly. So they have it like in 1 week, and in 3 weeks' time, it's gone. So actually, it's only a kind of smallish proportion of people that when they catch COVID develop a decent immune response. And therefore, we can't rely on it. What it does mean is that we think that may help us a bit over these difficult months, but not hugely. It's not going to make a massive amount of difference. If people who caught it were really developing very, very strong immunity and we were still seeing that 10 months after, because remember the first people caught it in March last year, quite big numbers. So we are looking at what happened to them. We will be seeing slightly different patterns of infection, and we've got clear evidence of people catching it more than once. The reason we vaccinate people who have been infected is because think of vaccine like doing an exam, and Dina will talk in more detail about this, but it's a bit like with 2 vaccines, it's a bit like doing your GCSE and then your A level. Those of us that did GCSE maths, for example, let's do a different one. GCSE IT, I did GCSE computers. If you really asked me to write a piece of code, I probably could just about do it now and make a little dot move around the screen. If I'd have done A-level computers and IT, that ability, I'd always be able to write code. And that's why you use 2 doses of vaccine. It's kind of teaching you to be competent and then teaching you to be competent for the rest of your life. If you've got natural immunity, the vaccine's just like an extra test. There's no harm in giving it to you, and it just reinforces what you've got. But there's also no point in testing people for antibodies before you give them the jab, because we know so many people, those antibodies just wear off over time, and the body doesn't kind of remember and mount a response again. It seems to have forgotten completely. Mr. Ali asked about attendance, and that he'd heard that 45% of Pakistani community hadn't turned up for their vaccine appointment. I haven't seen that stat, I'm afraid, Mr. Ali. I have seen data from the NHS, and it is provisional and it is restricted, which is why we can't share it with you. And there's a whole kind of argument going on with National about what can and can't be put out. Is that in some parts of the city, there's been up to a 50% decline. So it's not that they said yes and didn't turn up. It's that when they were asked, did you want to come for an appointment for your vaccine, that up to 50% said no. And that was more common in parts of the city where we had much higher Asian and African and Caribbean communities. And it's also much higher in some of our most deprived communities as well. So we've still got to do quite a lot to help people understand this vaccine is safe and to take it, because it is only being offered to people who are at real risk of dying. So that's really, really important. So I'll just cover the last couple of questions before I hand over to Dino, because I'm eating into his time, and I'll try and be short. So death figures. Chris and Rain asked about why death figures. Why do we do 28 days within a test and death certificate data? Both of those figures are now reported publicly. The reason we do the 28-day one is that your death certificate has to be submitted within 28 days of you dying, and then it takes another couple of weeks to get on the national database system. So getting the data for the death certificates is quite out of date. Whereas the data on who's died and had a positive test in the NHS is much faster. So the government's trying to balance, anyone who died within 28 days of a positive test, which includes people who got hit by a bus, which clearly isn't a COVID death, and the much more accurate data, which is the death certificate data, but it's 6 weeks out of date. So that's why they present the two data, and they are now published. For Birmingham, very, very little difference between the two. When you go back and check, it's a difference about 4 or 5 deaths. It doesn't make that much difference. I'll leave the vaccine questions. Hannah's asked a really technical one. I get the sense, Hannah, you might be a scientist, about a genetic marker that people might be more susceptible. I haven't seen that actually, and it hasn't been raised in my weekly conversations with the CMO, and we do keep asking. But if you do know of a paper about this, ping it into the team and they'll pass it over to me so I can ask the CMO's office. Yeah, thanks. So ping that through to me. But ultimately what we're seeing is that the bulk of the difference in transmission is about exposure, and that more people in our ethnic communities have been exposed because they work in jobs where they can't do them from home. And that explains more of the transmission, and that also they tend to live in larger family households. So when you look at where we've got larger households, so households with 6 people in rather than 2, where we're seeing clusters, we see that much more in parts of the city like Spark Hill, Holyhead, Handsworth, which tend to be some of our more ethnically diverse communities. Now, that's not saying we don't have big white families in the city, we do, and we have seen some large clusters like that in areas like Shard End and Ward End, but that's one of the other reasons. So it's not necessarily about susceptibility. Where we also see differences about mortality, and that's much more about health inequalities and your baseline health state before we came into it. So I think on that, I'll probably, final one for me, someone asked about classrooms and how many kids in a classroom. So the schools all have to and have been doing risk assessments based on how many children they can have in a classroom with distancing, with all the risk management and the bubbles and everything else. And it is slightly different at different ages. Now, at the moment, that risk assessment hasn't changed in terms of, because of the new variant, you don't need them any further apart. But I know that is being looked at nationally again about whether they want to change some of that advice just to put more distance between children. But we'll see. I think that we'll see whether that changes in time. So I'm going to stop today and hand over to Dino, because as usual, I've gone on far too much and drop off the call. But I will be with you, I think, next week again to join for part of the call. And any additional questions, ping them through Holly May, and she passes them through to me and the team. All right. Thank you again for all your support. I'm super excited. We hit 550 champions this week. My target is still over 1,000. So please go and, nobble your friends, get them on board as well, because I really want us to get up into 4 figures if we can. So over to Dino and Holly May.
Thank you very much, Justin. Are you ready to share your screen, Dino?
I am. Hello, everyone. I'm gonna do that. Boom. Can you see it?
I can, yes. Jack, can you see it as well?
Yep.
Excellent.
Yep.
So without further ado, welcome everyone to this primer on testing, immunity, and vaccination. First of all, as Justin has introduced, I would like to thank everybody for your participation and for the role you play in the community as COVID champions. This is very appreciated. The numbers are going up. It makes a real difference. Thank you. This presentation will be divided in 2. It's meant to be a primer, so very basic, just to bring everybody up to speed with some concepts. We're going to look at testing and vaccination. So the purpose of testing, what we test for, which technologies we're using, what are the strengths and limitations, and we'll look at the availability with a couple of maps and one of the most common pitfalls at the end. Then we'll be having other sessions in the future. We'll look into more details into vaccination, and I'll speak about that in the section related to it. So testing for a disease, a condition, is something that we do very regularly. It's something that is done in one of the most common things we do in healthcare and public health. So generally the reasons why we test can be resumed in understanding what makes us ill and plan an appropriate therapy. So how to treat a person, knowing what they have and use the right therapy to treat that condition, or catching a communicable disease early to stop the chain of infection. And this is the public health rationale, what we do in public health. Or we want to map the spread of disease over space and time, understanding how it's going, it's accelerating, it's spreading, it's contracting. And this is what we could say is a surveillance and monitoring rationale. Or we could look at aspects of immunity and genetic variants of the virus, and we look at how many people have encountered a disease or developed immunity. And this is what usually we do in research with immune assays, and we look at immunity with blood tests. These are general to all conditions and all diseases. We're not just talking about COVID. This is what we do regularly with any disease, with flu, with bacteria, and other things. What can we do to test? So what is the testing routine? So usually what we do is we take a sample from the body, from a certain site. This can be a sample of blood, a sample of urine, or we could take some cells with a biopsy or a swab, or we can take some mucus from the nose or the throat, like we do with COVID. And what do we do with that sample? We look at it in some way. So in some cases, we can look at it under a microscope. Bacteria may be colored. We may look at it under a microscope. It may be a very strong telltale sign of a condition that you're suffering from, or we can culture it. We can make it grow in a broth or a medium that bacteria or that organism likes. Viruses are not among these. They don't really like to be grown. They're quite difficult to grow. And therefore, we could use assays. So we can look at chemical or immune properties of that bacteria or virus to look at which one it is. What do we do in terms of specific COVID testing? So for COVID specifically, we look either for genetic material. So we look at the RNA that is inside the virus, which is a sort of barcode that's very specific for COVID. and we do this using a very sensitive PCR test, which I will talk about later, or we look for proteins, so the building blocks of that virus. We look at them, and we look for them with some test, a quick test called lateral flow test. And again, I will explain exactly what is that later. Or we look with a blood test, we look at antibodies in the blood. And this is done, as I said before, mainly for research. So we're not going to go into that too much because it's not something that we do routinely or that is very useful at the moment. This is a recap of the test, just graphically to visualize. You can see this is the molecular test, the PCR test that looks at what's inside the virus, which is the genetic material. In the middle of the column, I'm going to cover it because antibody test is just going to make confusion. So that's gone. And this is the PCR. So we multiply it, we make it more visible because it's a very small molecule. We want to make sure that we see enough of it to test it. Or we look at the proteins outside the virus. And in both cases, we use a swab. We take some mucus from the nose or the back of the throat. But in this case, we try to highlight the presence of that protein with some colored dyes attached to some very reactive proteins that bind to that specific protein. Both are tests that tell us whether the virus is in us, in our mucus, in the noses or in the throats. In one case, very sensitively, we look, and here I'm going to talk about the pros and cons of both. With a PCR, we're going to be very sensitive and very specific. So we're going to take certainly COVID and nothing else, and even very, very small particles of COVID, very, very small chains of that genetic code. This extreme sensitivity is a very strong element, strong characteristic of PCR, but it's also his Achilles heel, because you might get some snippets of that code that are remnants of a previous infection that are lingering in our nose. And therefore, that's why we say that once you do test positive with a PCR, it doesn't make a lot of sense to do another test within a few weeks or months because you're likely to still be positive. The other weak point about PCR is that it can take a bit of time. So it's not something that we can do on the spot and tell you a result in a few minutes or in half an hour like we do with other technologies. And it's also a little bit expensive, and it needs lab equipment and trained personnel to be conducted. Well, instead, the lateral flow test, also known as the quick test, rapid test, which we've been deploying around the city, is very rapid. So results can be given within 30 minutes. It can be conducted on site in front of you, and without particularly specialized equipment. It still needs trained staff, as Justin said, is not something that can be done by yourself at home, although we're hoping that further regulatory and advancement in technology might open up that avenue. It is still very specific, but in terms of weaknesses, it's not as sensitive as PCR, which may be a pro and a con, as we said before. We may not detect people who are not infectious anymore, and we are most likely to detect a person as positive to COVID when they are most infectious. So it might be useful for that. But still, we are likely to miss somebody that might be still incubating the disease and have very little of the virus in their nose. And we're looking with this test for pieces of the virus, the protein around it, the case of the virus. We're not looking for genetic code. So the routine that we are suggesting with lateral flow testing for our healthcare staff and other staff that can benefit from this is to test every 3 or 4 days. And we have a very large capacity to do this, as Justin said, in Birmingham. These are the lateral flow testing sites. As Justin said, we have a capacity of between 14,000 and 15,000 lateral flow tests a day. We have some static sites and some floating mobile sites that will move around in different days. And that allows us to cover better the territory of Birmingham. This map will be out of date in a few days once the mobile test sites relocate to other sites. And you can book your test on the council websites, and this is done for asymptomatic people. So if you don't have symptoms, you do a routine test if you're wanting to know whether you have COVID. Instead, for PCR, which is the test that we discussed that looks at the genetic code, it's a bit longer, is the test recommended for people with symptoms. And in order to book one of these, you go on the NHS website or you call 119 and book one of them. This is again the map. The map shows where the static sites are and a few mobile ones, again, roaming. And we obviously recommend that you go and get tested if you have symptoms. And this is the distribution of them on the map, which would make it easier for you to reach one of them. This is the caveat that I was telling you before. What do I do if I am negative? Does that mean that I am safe? In reality, being tested negative doesn't really mean that you can change your behavior, because a test can only tell you what is happening in the specific moment in which you took the test. It doesn't tell you anything about the future. So you could easily become positive after taking the test, or as in the case of the lateral flow test, already be positive and be incubating the condition. So you should not change any of your behaviors if you receive a negative test. Obviously, you should change your behavior if you receive a positive one in terms of isolating. But what it means is that you keep observing social distancing and infection control measures like washing your hands and not touching your face and covering your face.
Dina, I'm so sorry to interrupt. Would you like questions at the end, or would you like them sort of throughout?
We have questions in between, but I don't know whether if it's more efficient to take them all at the end, just so we don't break the flow. What do you think? I am, as you say, I'm cool with either.
Well, at the minute we've got one question, so perhaps we'll answer that one, and any more we can save for the end. So the question we have is, how many PCR cycles are our labs doing?
That really depends. I am not cited to the exact statistics. The amplification of a PCR is done to reach a certain level. So it really depends on how much genetic code you have at the beginning, as far as I know. But I'm not a lab technician and I'm not cited to exactly what the sensitivity has been set for these tests. A PCR cycle, just for everybody to understand, is how many times we take one of those molecules of genetic code of the coronavirus and we replicate it to make it visible, in the sense that are very small. As we said, we want to amplify them and make them visible. And this is done by cycles that double it every time. So I personally don't know what is the threshold that's being used at the moment in the labs. And there are, in many cases, national labs that do it for a variety of regions. If that was the question, I could move on to the section about immunity and vaccines.
Yeah, that'd be great. We'll save the rest of the questions for the end, Dino. Thank you.
Thank you. So this is the section instead dedicated to a primer on vaccination. There will be future sessions that will look more in detail into the actual technology of each vaccine and the differences between them, and any myths and misunderstandings and issues with the vaccines themselves. First of all, to understand vaccines, we have to understand what is your immune system. So just in very broad terms, it is a system of progressive barriers to prevent invasion from external pathogens, among which we know there are viruses and bacteria. It is made of passive, active and specific defenses. So these passive structures, probably it's easier to visualize this way, are the physical barriers of our body. So the skin, the mucous membranes, the acid of our stomach, or even coughing and sneezing allows us to expel these invaders before they infect us. Once they are inside of our body has some quick measures to fight it, which are fundamentally cells that will envelop and eat and digest the invaders, which could be, again, a bacteria, a virus. And as you see, there is an arrow that shows time, means that this is the speed at which these happen. So then we have an adaptive, acquired, and more elite unit of response, which is able to mount a much more effective response to a specific invader. And that, though, takes a little bit of time. And this is just start introducing the concept of priming our immune system through a vaccine for a more effective, more strong response to an invader. Sorry, okay, I was clicking on the wrong button. So our immune system, as I said, it automatically will eat up and swallow and digest an invader. So basically, once it's done so, it will present these parts of the invader, sometimes pieces of proteins on its envelope or outside it, to the surface of the cell, and it will present them to the elite soldiers, which will instead prepare a more specific and effective and long-lasting plan, which is called the immunity, to future encounters with this invader. So these are processes that apply to every infection, and not by chance this graphic shows fundamentally a bacteria. So we can see it again here. The macrophage, which is one of those cells that envelop and eat up the invader, in this case a bacteria, will break it up and show it to other cells, which are the elite cells of the immune system, which will train themselves to produce antibodies or to produce T cells, which will retain a memory of that encounter, in order for the next time to cut the middleman or the macrophage and immediately be ready to attack an invader of the same kind. So this is fundamentally a training that happens in this case in an emergency situation where the infection has already happened. But if we go further, it will happen already, because we have already encountered that invader. So looking at COVID as a virus, its anatomy, we can see that it's fundamentally a bubble of lipid and proteins surrounded by a series of hooks called spike proteins, which are the grappling hooks that the virus uses to bind to the target cells. And this is a target that we are using also with the vaccine, and the antibodies naturally develop some immunity to. I wanted to mention the lipid structure also, because this is what we tend to dissolve with soap, and that's why soap is so effective in dealing with the virus. It's fundamentally a bubble of oil that we can dissolve with soap. So it's something that has to be borne in mind. I mean, viruses are not that resistant. If we wash our hands and clean the surfaces, a virus will not survive there. So just a recap, we got to explaining what immunity means. So the important thing is that for an adaptive specific response, the body needs time to train the elite forces that are effective to target the specific weakness of this invader. So these are the antibodies, and you will see it mentioned in the media, the T cells, which are memory cells that allow us to keep a memory, a running memory of this encounter, which is an encounter with the vaccine or with a real pathogen. As Justin said, unfortunately, the natural immunity to COVID is not as strong as that we can elicit with a vaccine. How do vaccines work? As I said, a vaccine is a general rehearsal of an actual infection. It is a way to provide the body with a specific plan to fight a specific invader. So they give us time, they buy us time and stage this military exercise where our elite troops are trained beforehand. And this is fundamentally because we don't want an infection to take us by surprise and be able to cause us symptoms. This is just to show what happens. So the vaccine shows the body the spike protein, or in this case, a protein from the flu vaccine is exactly the same thing. The immune system trains on those things, gets a perfect match to that protein. And then once the actual invader has come into our organism, we already have those well-tailored antibodies to attack and neutralize the invader. We want to prevent, obviously, severe disease with this. And so this is what we do at the beginning of a vaccination campaign. We prioritize those people who have the highest likelihood of getting the disease or getting severe symptoms from the infection. This is at the beginning when we have little vaccine available. We're starting a vaccination campaign. We start from those that are most likely to benefit individually from it. And then hopefully once we have built the stock of the vaccine and we start distributing it throughout the population, we will also be able to prevent spread and develop herd immunity. For the vaccine, the actual evidence of the vaccine ability to prevent further spread is something that research is still working on. We need more data. Obviously, it's something that can't be researched until we vaccinate the whole population, but it is something that we are pretty confident and hopeful that will happen. What is herd immunity? That is another concept that we heard in the media quite a few times, and it has to be visualized as, for every vaccine, as the let's say a set of firewalls or fire breakers that impede a fire from rage through the entire forest. So we have vaccinated a series of individuals. Those individuals cannot be infected, therefore they are not able to allow the virus to rage uncontrolled across the population. That's what we are hoping to achieve with a mass vaccination campaign, and we're hoping to achieve for a mass vaccination campaign of most diseases. It is not specific to COVID. How is the vaccine given? You probably have seen pictures of Mr. Shakespeare having his vaccine in Coventry. It is an injection in your shoulder muscle, and it is given in 2 doses, 3 to 12 weeks after the first, because we want to reinforce the response. So a second dose is used to improve effectiveness. It's the same thing that we do with the MMR vaccine and others. And in other cases, when you see that you have, for example, like in the flu vaccine, a series of vaccines every year, it is because the virus changes. In this case, we expect that you might need some boosters, but there hasn't been any evidence at the moment that any of the new variants are resistant to this vaccine, so it should be effective. Is the vaccine effective? I ended well. The previous one, yes, it is very effective. The first dose already should give you a good protection, and as we said, the second dose will boost its effectiveness and its duration. It will give a second, let's say, dress rehearsal to the immune system to make sure that it is strong and up to the fight once the immune system encounters a live coronavirus in the wild. Again, as I said, there is still a chance that you can get the coronavirus and potentially spread it, although you will not have a severe disease. So you should still observe all the infection control guidelines out there at the moment. Is the vaccine safe? The vaccine has gone through the strictest regulatory processes. It's been authorized for use nationally and internationally, and it has been licensed for use with all the trials and safety checks that other licensed medicines have to go through. And we have already seen from thousands and thousands of people that have been vaccinated that serious side effects, such as allergic reactions, are very rare, and there's been no long-term complications reported. In terms of the more common side effects, which are, again, true for all vaccines, flu included, and as you see, the picture that I present here is for the flu, you will see they're exactly the same. So we have a little bit of localized sore and tenderness. You might feel a little bit tired. You might develop an headache. You could have a little bit of nausea and feel ache in your muscles, but it's something that's transient, and it's just the sign that your immune system has been woken up and asked to prepare for a dress rehearsal, as we say, for a military exercise. Who can get the COVID vaccine? At the moment, as I said, we are targeting those that are the most vulnerable. So people aged 80 and over, people who live or work, so the staff and the residents of care homes, and the healthcare and social care workers that are at very high risk of contracting the disease because of the job that they do. And the offer of the vaccine will be widened to other categories, and we're working at the moment, I mean, the NHS is working at the moment to allow the vaccine to be dispensed in a vast number of settings that are beyond the hospital. In some pharmacies, we're seeing hundreds of local vaccination centers run by GPs and other settings coming online. The prioritization is up to the Joint Committee on Vaccination Immunization, and there will be updates as we progress with vaccination across the population. Again, as we're testing, there are caveats, and I said it before. The question is, I have been vaccinated now. Can I stop social distancing? We obviously all would like to return to normality, but there is at the moment still a chance that even if you've been vaccinated, you might still get and potentially spread the coronavirus. Therefore, it's important, even if you've been vaccinated, to continue to follow the social distancing guidance and other infection control precautions. And this means fundamentally to wear a mask when you're indoors. So the hands, face, and space mantra that we've been repeating still applies, even if you've been vaccinated. We're still in that phase. And with this, I think we have reached the end. I thank you. This concludes the first session of this primer on testing, immunity, and vaccination. And there will be others that will look more in detail into the technology of the vaccines and the myth-busting effort. If there are any questions, I'm very happy to take them. Thank you.
That's great. Thank you, Dino. And before we do the questions, we actually have Rizwan Aladina here from the CCG, who's looking after the vaccines, and they have an update for us. Do you want to give us that first? Because that might answer perhaps some of the questions, and if not, we can then do the questions.
I'll stop sharing the screen.
Oh, thank you.
Thank you. Thank you very much, everyone. It's great to see so many champions, and it's quite heartwarming on behalf of the CCG to see so much interest from the community, particularly because we are quite interested in making sure that we engage with all our communities to make sure that we have a good uptake of the vaccination. So the good news first. The good news is that the Midlands is leading the way in the amount of vaccinations that we have given so far. National figures so far is showing that we have given over 447,000 vaccines as of the 14th of January, which was yesterday. So I think we are ahead of a lot of the other regions, including London, and it's nice to see that we are building up the protection and immunity to our population at speed. So as you may have known, there are a few places where you can get your COVID vaccine from. Obviously, the hospitals are giving them to health and social care staff, and they're also giving them to patients over the age of 80. GP hubs, there are about 27 of them operational at the moment throughout each primary care network within Birmingham and Solihull, and they are also doing vaccinations at pace. And obviously our flagship, which is the Millennium Point, which is the mass vaccination site, went online from Monday, the 11th of January. Now they're achieving over 1,000 vaccines a day, and there is plan to scale up to over 2,500 a day as we go along. Things are actually working very, very well. Just a few points that we wanted to highlight, which are messages which we can give out to friends and family and others. And that is that patients do not need to contact practices or other NHS services for their vaccination. They will be contacted as per their prioritization. And yes, there have been letters going out, so hopefully that will be something that is forthcoming. And we are quite proactive in making sure that everybody is offered a vaccine that requires it. The second thing is, obviously, the enthusiasm is there, and it's nice to see. But people are arriving a little bit earlier for their vaccines, particularly at the Millennium Point, than they need to be. And because of social distancing, it's becoming a little bit of a difficulty. So if people can arrive on time rather than early, and I don't fault their enthusiasm, sorry, but it's just something, it's a message to get back. But we're doing well, and we hope to do even better. And hopefully the ray of light we have in terms of the vaccination, which is the way out, we're trying to do that as quickly as possible. Supplies are regular, and there are no sort of problems that are being foreseen at this point in time. So let's keep encouraging people, and particularly those from BAME and ethnic minority communities, where there's been a slightly higher refusal than normal. If we can obviously please encourage them to take the vaccine as much as possible, I think that would be a very helpful message. The CCG will be working with hard to reach groups like mosques and other churches and other places, to engage on one-on-one conversations with them, and hopefully also develop videos and promotional materials which will help encourage those people to take on the vaccine and ensure them it's a safe vaccine to take. So all I can say is that I think we're doing well, and we hope to do even much better in the future.
Oh, thank you very much. Oh, hello there. Thank you very much for that update. So I'll go through the questions. Some of them are about the vaccine, some of them are about testing. It's great that we've actually got you here as well, Rizwan. So perhaps Dino and perhaps you both could answer them potentially.
No problem.
One of the first questions is about testing. So how accurate is the lateral flow test? Dino, this might be for you.
Yes, the question about accuracy has to be seen under a range of dimensions, in the sense that when we test, as I said, we test for something. So the first question is, are we having a positive to that specific something, or are we having a positive for something else? And the lateral flow test in this respect is very accurate, because it will tell you that you have COVID, it will not tell you have something else. As we said before, the lateral flow testing is not very sensitive. That doesn't mean that it will give you a bad result. It will mean that it will not be very able to show that you have an infection when you have very low levels of that infection in your nose, which is fortunately also one of the hallmarks of infectiousness. So you will be more infectious when you have a lot of that in your nose. So the lateral flow testing is good at detecting infectiousness, so the stage in which you are more likely to infect others. So in that respect, is quite accurate. Although it might tell you that if you're still incubating a disease, you're negative, and you might become infectious and positive later. That's why we recommend that you do a serial testing. So you continue testing every 3-4 days with lateral flow testing, because that is the most certain way to identify an infection which otherwise is below the threshold of detectability, which is exactly the opposite of PCR, where the PCR is sensitive even to the halos, to the remnants of a done and dusted infection for several weeks and months afterwards. So it's a pro and a con in a sense of this testing, but the rapidity and the ease of use is outweighing at the moment.
And just to add to that, Dino, sorry to interrupt. I think the key thing here is to know whether we are safe to be at work or in an environment that we are. And if we rely on PCR test, which takes time, it is going to be difficult to know. I mean, for instance, when I was going to do my care home visits for vaccination, I needed to know that I wasn't carrying COVID. And I can't get that information unless if I do a lateral flow test. So I think it's an acceptable test to know whether you have COVID or not. I think it is sensitive enough for what it is required for. So I think there is no reason not to trust the test as the results come through.
That's really helpful, thank you. I'm just looking for the next question. So Paul is asking, is it worth taking the vaccine if you've already had the virus?
Yes. The answer to that simply is yes. Because like Justin said earlier on in the meeting, we are not sure exactly how much immunity you build up from getting the disease itself. You may be in one of the 1/3 who get a good immune response to that, or you may be in the other third that you may not get an immune response to that. But nonetheless, having the vaccination will give it another trial run for your immune system to actually build up the immunity, and if nothing else, to give a booster in that respect. So even if you've had it within the last 3 months, in fact, they say you need to have you need to be COVID-free for 28 days before you can have the vaccination. So even after 28 days, when you have immunity, you should still have the vaccination because it will boost your immunity.
Thank you. I'm aware we're probably going to go 5 or 10 minutes over. If anyone can't stay, thank you for joining. But if everyone is okay to, perhaps we'll just extend this by 10 minutes or so. We've had, Magda, your question around myth busting and resources, that links in really well to a meeting that I had this morning. So I'll take that offline with you if that's okay. We've had a couple of questions around, so what is the likelihood that people who have been vaccinated will get COVID? And somebody else actually said that they know someone that's been vaccinated that then got COVID. Are you able to perhaps just talk to us about that a little bit?
Yeah, sure. So I think the studies are showing that we do need a booster at the end of the day. So one injection will give us enough immunity. And the hope is that if enough people have had the first dose, we will build up enough sort of herd immunity to be partially protected as such. But as an individual, having had one injection of vaccination, you will build up a partial immunity, you will not build up a full immunity. So you could, in theory, have a COVID infection afterwards. And that links to another question regarding the scientific studies, which is further down in the Holly May. I may as well tackle it right.
That's fine, no problem.
The endpoint for all the studies was actually getting a COVID infection. So in theory, yes, whilst transmissibility and other endpoints were not looked at within the studies themselves, the fact that they looked at actually getting COVID is a good thing, because what happens then is that if you don't get COVID, you don't get the complications and you're not transmitting. So therefore, it's a valid endpoint to have for a vaccination trial, essentially.
Thank you. Alison is asking, does supported living come under the care home setting for vaccines?
Difficult question. Supported living is slightly different from care homes, because care home residents are entirely dependent on their carers, and they have a higher load in terms of interaction with carers as such. Supported living can have a little bit of self-isolation or social distancing as such. So it's slightly different, but not to misjudge. They are obviously at-risk categories as well, because most of them will be vulnerable, and they will be in the higher categories in vaccination in most cases.
Thank you. Hannah is asking, so how are we deciding which patient gets which vaccine? Are people able to choose? Are they not? Yeah.
So the criteria for which vaccine you get is somewhat out of our hands, in the sense that it depends on supply. It depends on the patient themselves, and particularly for those patients who have been having severe allergies or had hypersensitivity, then the AstraZeneca Oxford vaccine is more suitable for them, because we haven't had much in terms of allergic reactions, etc., from the AstraZeneca than for the Pfizer. But in whole, being pragmatic, it depends on what is available and what we have available, and also the number of doses that we get. So for instance, if you, on a more pragmatic standpoint, if you get a pizza box of Pfizer vaccines, there are 975 doses. You have to use them up within 3 days. So, and AstraZeneca obviously can still be kept in the fridge and can be used for care homes, and where transportation for Pfizer vaccine is quite difficult. So there are quite a lot of factors in terms of which you're likely to get. In the mass vaccination sites and GP hubs, you're more likely to get the Pfizer one than the AstraZeneca. In the care homes, you're more likely to get AstraZeneca over Pfizer, just because of the ease of transport.
Thank you. So just because of time, we'll do the last question, and any questions that aren't answered now, we will endeavour to answer by email. So Fiona says, after the first vaccination, those people that perhaps do get COVID, will it be in a less severe form?
Yes, is the short answer. Because the endpoint of the studies was actually not getting the COVID infection itself, the likelihood that we think at the moment is like the flu vaccine, that if you do get the COVID infection, it is likely to be less severe. But the studies haven't looked at that as an endpoint. So the jury is out. That obviously this is very new technology. This is very new vaccine. So we're still learning as we're going along.
Thank you. So I think we'll leave it there. Like I say, we'll answer any of the other questions that we have. Thank you all for joining. We will send out the dates for the next, for session 2 and 3, so you can find out some more. And we'll also send out the webinar link as well that will be on our YouTube channel. Have a lovely evening. Thank you very much, and take care, everybody.
Thank you. Goodbye.
Thank you. Bye.
Thanks all. Bye.
Bye.